Wana jemi jolongombele dule no londana ohongale longombi nyangu ngwiru gale nyamu londana ngulali moina go wani hola no jirongo kombo angu jomuva mi jongombe olombale mbajirwa gonjo gerombwe gonjo kolonalo tumana tuevali olumana.
Namibia is a stable, young democracy in southwestern Africa that attained independence in 1990. Famed for its magnificent scenery and abundant wildlife, Namibia is today a premier African tourism destination and is classified as a middle-income country. Namibia has made commendable progress in offering primary education, eradicating extreme hunger and poverty, ensuring environmental stability, achieving gender equality, and combating HIV and AIDS, and is on course for attaining the related 2015 Millennium Development Goals target in these areas. Regarding maternal and infant health, however, the situation is far less satisfactory. The infant mortality rate is over twice the 2015 target, while the maternal mortality rate is over 6 times the target. So why are these statistics so alarming, despite the fact that maternal health services are available in regional centers across the country? A crucial factor is that 10 to 15% of deliveries in Namibia take place at home, without any maternity care, predominantly in rural areas. Even though Namibia is classified as a middle-income country, the distribution of wealth is highly skewed, and rural communities are generally amongst the poorest. Added to this is the fact that Namibia is a vast country, about the size of Spain and Italy combined. Without access to any public transport, impoverished pregnant women from rural communities must travel substantial distances, often over 100 kilometers, to reach the centers. Despite these difficulties, many do come to the centers, but they must make whatever plans they can to stay for as long as 2 months, to be sure that they receive antenatal care and are as close as possible to the hospital when labor begins. Hambaleleni Jonas is camping in an open field near to the Okongo Hospital in Namibia's Ohangwena region. She says that conditions there are really tough. The women have no security against passers-by, and pigs roam freely throughout the camp. When it rains, they can't cook. Hygiene in the camp is poor, and the women shower in the open, with only the most rudimentary means of ensuring some privacy. She is grateful that a maternity waiting home is being built in Okongo, as it will greatly assist pregnant women in the future, even if it is not completed in time for her to occupy. In Inyana, about 100 kilometers away, there is a woman's home for expecting mothers that has recently been upgraded and expanded through the addition of 2 new dormitories. Although it still cannot satisfy the demand for appropriate accommodation, the environment it provides for the residents contrasts sharply with that in Okongo. The atmosphere is relaxed and friendly, with the women involved in productive activities and assisting each other with daily tasks. They must each pay a small daily amount of $2 per day to stay in the hostel, but this can be paid in kind if they do not have any money.
The mothers here, they are like sisters. They have got a teamwork. The cooperation is good here. As you know that they do things collectively, like preparing their food as well as cleaning. We do not have a cleaner here. They clean for themselves. The mother here shows the spirit of teamwork and cooperation. There are so many challenges, and one of the challenges here is finance, resources. As you can see that our center, it needs to be extended. Yeah, the mother here are paying little as they can. We are charging them $2.50 for staying here per day. However, they can also pay in kind.
In Congo, however, until the maternity waiting home has been completed, pregnant rural women will have to continue to camp out in near squalor if they are to have their babies in a hospital rather than at home. This phenomenon is by no means limited to Ohangwena region, however. At other centers with hospital facilities, women must make whatever plans they can to be close to the hospitals. Doing so can be an arduous undertaking and one that is fraught with dangers, especially for women living in more remote, underpopulated areas. Namibia's Kunene region is vast, forbidding, and starkly beautiful. Although over 10 times the size of Ohangwena region, it has just over a third of the population. It is home to the Himba people, who today still mostly tend cattle and goats and follow their traditional lifestyle. They are renowned for their striking appearance and dress, and smear their bodies in a mixture of ochre, butterfat, and omumbiri, a sweet-smelling resin they collect from an endemic commiphora bush. At Ochisoko Chongava village, north of the regional capital Apuo, times are particularly hard. 4 years of drought in the area have denuded the sparse grazing, and the community's cattle have all been sent far to the north, close to Namibia's border with Angola, in search of patches where some rain has fallen. Goats and chickens are all that remain for slaughter or bartering. Water must be brought in, against payment, from a village in the next valley, where there is still a functioning borehole. The maize that is ground by hand must be bought with the scant cash that is available. Mukinambinga Chavara is expecting her second child. She explains that in her Himba tradition, when a young woman is pregnant, her mother plays a central role. From about the 5th or 6th month, she will spend most of her time with her mother. This continues through to the birth of the child, and for the first months of the child's life. If her mother has passed on, another family member will take her place. The first time she felt pregnant was confusing for her. She noticed that her menstrual cycle had stopped, and she was vomiting a lot, but she did not yet understand what this meant. She confided in her mother, who realized that she was pregnant. From then, she moved into her mother's hut and was with her all the time. Her mother started giving her different food and made sure that she got enough to eat for herself and for the baby. She went to Apuo during her pregnancy to check that the baby was well and closer to the time to give birth in the hospital. But this was not easy. In her village, there are no cars, and they do not have a donkey cart, so she had to ride a donkey. Her mother went with her for these visits. With her current pregnancy, she started going for checkups at 5 months. When in Apuo, she and her mother stay in a tent in the yard of people they know. A problem she has experienced has been that it takes so long to get help at the clinic. The lines are very long, and if you are not seen in time, you have to wait a few days because the nurses do not check on unborn babies every day. But the important thing is that all the signs are good, and her baby is healthy. When told of the planned maternity waiting home, she said that it is an excellent idea. It will make things so much easier for women like herself. She only hopes that it will be ready in time for her baby. Ochisoko Chongava village is only about 20 kilometers from Apuo, but living in a village in Kunene region may mean being more than 100 kilometers from the nearest center. An arduous journey awaits pregnant women coming to Apuo for antenatal care or to be near to the hospital for the onset of labor. Many villages are far from the nearest road, and the journey may begin with a long walk in searing heat.
Omukabe ndikiapo mbandukiro edu mukiri wonga na hi uliko kule no kipangero.
As the senior traditional leader of the Kakuru Konje Traditional Authority, Karongojo Moheje is well aware of the difficulties faced by pregnant women in rural areas. They come to town with their mothers, husbands, or sisters. They will never come alone. Transport is a major challenge. Some set out, but have left it too late and give birth along the way. Others arrive when complications have set in, and it is too late to save the baby or the mother. Very few women can afford to arrange for a lift in a car when they need it, so getting to Apuo may entail many miles of walking and riding on a donkey or a donkey cart. However, it is on reaching her destination that a woman's problems can really begin. It is commonplace for pregnant women from the poorest communities to have to survive in the most rudimentary of shelters while they wait a month or two for the onset of labor. Those fortunate enough to have relatives or friends in town might be able to set up their shelters on their property with at least the basic protection afforded by a perimeter fence, and others camping in the same situation. In Karongojo Moheje's own yard, community members are staying in tents and even more basic shelters because they have nowhere to go while the pregnant women wait to give birth. This is a problem throughout the region, he says. He is a member of the committee that is planning the Apuo maternity waiting home. The intention is for the home to cater for women who are most at risk. Their mothers should also be allowed to stay with them. It should give them the protection from the elements before they give birth, and also for 4 or 5 days after they are discharged, thus avoiding deaths of mothers and newborns, which often occur during the first week after giving birth. For these women, the poorest of the poor who have no one to turn to, the conditions almost defy belief. When faced with prospects such as these, it is small wonder that many rural Namibian women opt to stay in their villages to give birth. Nationwide, 10 to 15% of all births in Namibia are home births. In Kunene region, this figure is over 1/4. In some cases, this might simply be a matter of choice or tradition. But the willingness of so many women to endure appalling conditions in order to have maternity care during birth is clear evidence that its benefits are widely understood and desired. Namibia's First Lady, Madame Penehupifo Pohamba, has long been a champion of maternity care. In exile during Namibia's struggle for independence, she trained as a midwife, and she is Namibia's patron of maternal and child health. She played a critical role in liaising with the European Union and the World Health Organization, who decided to fund and implement the planning and construction of maternity waiting homes through PARMaC in 4 regions with substantial rural populations.
We have seen that we are having women who are really challenged with a lot of situations, especially the long distances to come to the facility where they could be taken care of, the lack of transport, and the lack of even money to pay for the transport if the transport is available. These challenges really have put a lot of women to be in their houses, not giving that care while they are pregnant, during delivery, and after delivery. And as a matter of fact, their kids were also not able to be vaccinated. Therefore, I think it's very important to continue with this care of pregnant women and children. At the hospitals, they will be in the hands of the professionals, and a lot of care could be given to them. Therefore, those who are going to be at the home are only those maybe who cannot really make it, or who did not get the information that it's important for you to go and deliver in the hospitals or clinics where health professionals are. Myself, as a patron of maternal health and national agenda in this country, I want the care to be given to the pregnant mothers and the care to be given to the babies as well, so that we could have a healthy nation.
The importance of reducing maternal and child mortality is also recognized by the Namibian government through both policy and action.
I want to say the government of the Republic of Namibia, through the Ministry of Health and Child Services, is fully committed to ensuring that quality maternal and newborn health services are in place. We are cooperating with the European Union and the World Health Organization to reduce infant and maternal mortality rates in Namibia. Maternal waiting homes are especially vital in the provision of maternal health services in Namibia because of the long distances expectant mothers travel to health facilities.
PARMaC will run until 2016, supporting the Ministry of Health and Social Services with high-impact essential interventions. PARMaC approaches maternal and infant health holistically through integrated interventions. In addition to the provision of decent, safe accommodation for expecting mothers through maternity waiting homes, it also provides training for health workers in antenatal and emergency obstetric care, and equipment, supplies, and ambulances for hospitals and health facilities, and supports nationwide immunization campaigns. For example, with PARMaC's support, in November 2014, 2 new vaccines were added to those normally given to children under the age of 5 during the Maternal and Child Health Week. Pneumococcal vaccine, which will protect children against pneumonia, and the rotavirus vaccine, which will prevent deaths from diarrhea.
What we want to achieve with this program is a situation where if we have a healthy pregnant mother and we have a good health facility, the story ends with a healthy newborn child. So our program tries to address these different elements first through an education program directed specifically for the pregnant mothers so that they can decide when is it time to leave their village and go close to the health facility. We would provide also from some transport in the form of ambulances and so on. And finally, we will build some maternity homes where the pregnant mothers can stay next door to the health facility, receive there some advice, some training, and are ready just to move next door and give birth to a healthy child.
In Okongo, Madame Pahamba visited the informal camp where pregnant women are waiting to give birth, mingling with the women themselves and listening to their concerns. The first of the maternity waiting homes being funded by the European Union with implementation by the World Health Organization was nearing completion by the end of 2014. Together with the pregnant woman, Madame Pahamba visited the building site to view the progress. She made use of the opportunity to encourage them to access antenatal and maternity services and to ensure that their children were properly immunized. The homes themselves will provide a safe environment for pregnant women where they can prepare for giving birth in hygienic conditions. Each home will have dormitories, a kitchen, a dining hall and a meeting area, showers and ablution facilities, and a laundry. They will also ensure that the women receive all the antenatal care that they need and are properly monitored so that any problems can be addressed at once and they can be taken to the maternity wards in good time. Furthermore, they will provide an ideal context for health extension work so that once their babies are born, the mothers will be better able to ensure their continued healthy development.
I want to thank the government of Namibia for their leadership and commitment, and also as well as the EU for their financial support for improving maternal health, newborn health, and their survival. For us in WHO, women, particularly the pregnant women and their newborn, deserve the best. No woman should die giving birth, bringing life to this world, and their newborn should survive. Society and the government needs to be accountable for every death. We in WHO are very proud to be part of this initiative, making sure women gets the best they deserve.
Tongo noko mutarariro ndaye noko mutiri parata ye no manyina ngolomba vendo manango longombe wajiri hotanda vere miria raje kandi midukana nyoko